Okay, so this lecture is going to focus on gastrointestinal drugs, everything except for nausea and vomiting. Nausea and vomiting, specifically chemo-induced nausea and vomiting, are covered in another lecture video. We'll start by talking about peptic ulcer disease and GERD, gastroesophageal reflux disease or disorder. There are different causes of peptic ulcer disease. Helicobacter pylori infection is one of the most common causes. Infection with H. pylori or Helicobacter pylori is very, very common. H. pylori happens to be a bacteria that is happy to live in the stomach where most bacteria can't live. It actually goes down into the lining of the stomach where there's lots of protective mucus, and it lives happily there. It also happens to cause an ulcer there in that area where it's living. We'll talk a lot about how to eradicate H. pylori and treat ulcers that are induced by this infection. Chronic NSAID use is also a common cause of ulcers. Contributing factors to peptic ulcer disease include excessive hydrochloric acid secretion and insufficient mucus protection. So we can treat peptic ulcer disease by targeting either of those things. Usually we try and decrease the amount of acid that's secreted, but we can also try and increase the amount of mucus that's there. Therapy for peptic ulcer disease and GERD include antimicrobial therapy in order to eradicate the H. pylori infection if it's there. We use a combination of drugs for H. pylori. Reduction of acid via a proton pump inhibitor, a PPI, or an H2 antagonist, a histamine 2 H2 blocker. And then we can also utilize protection of the gastric mucosa with something like misoprostol, which increases mucus protection in the stomach, or sucralfate. We'll talk about all of these agents in this lecture. We'll start by talking about Helicobacter pylori or H. pylori. H. pylori diagnosis needs to be confirmed in order to treat for H. pylori specifically. When patients present with signs and symptoms that are indicative of gastric ulcers, we do test for H. pylori. H. pylori can be confirmed with endoscopic biopsy of the ulcer or much more easily with a fecal antigen test, a urea breath test, or serology. When H. pylori diagnosis is confirmed, combination therapy is utilized to eradicate the infection and help heal the ulcer. Combo therapy is associated with faster healing as well as decreased rates of relapse of H. pylori infection. Quadruple therapy is the recommended first-line therapy. Quadruple therapy includes the use of bismuth subsalicylate, which is protective, and then metronidazole and a tetracycline antibiotic, and finally a PPI, a proton pump inhibitor like omeprazole, in order to decrease the amount of acid that's being secreted in the stomach. Again, this is the recommended first-line therapy. Bismuth subsalicylate, which is like Pepto-Bismol, metronidazole and tetracycline to kill the bacteria, and then a proton pump inhibitor like omeprazole to protect the stomach by decreasing acid. Triple therapy can be used. Triple therapy includes a PPI, a proton pump inhibitor, and then 2 antibiotics. It uses amoxicillin and clarithromycin. If the patient has a penicillin allergies are pretty common. If the patient has a penicillin allergy, then instead of amoxicillin, you would use metronidazole. So triple therapy is preferred when rates of clarithromycin resistance are low in your area, and if the patient has no prior exposure to macrolide antibiotics. Clarithromycin is an example of a macrolide antibiotic. Another example that's really commonly used is azithromycin. This is Zithromax, like the Z-Pak. Again, the patient has to have no prior exposure because you don't know how long they've had the H. pylori. They could have been infected with H. pylori for quite some time, and if they've used that antibiotic recently and the H. pylori is still there, that means it must be resistant. So usually we end up using quadruple therapy. So here this is showing us the overview of management of an adult patient with peptic ulcer disease. So essentially what this is telling us is how long, or if we need to use a proton pump inhibitor like omeprazole, and how long we need to use it. And then also if we need to do H. pylori quadruple therapy or not. So initially we're saying, okay, does this patient have a complicated peptic ulcer? If yes, then here you see we do a proton pump inhibitor. We try and assess what's causing the disease. Is this due to NSAID use or not? Remember, we just talked about NSAIDs in another lecture, and we said that NSAIDs are associated most commonly with GI adverse drug effects, including possibly developing ulcers and that can bleed. We discontinue any aspirin or NSAIDs. If H. pylori is there, we eradicate it. Over here, if the patient does not have a complicated ulcer, we need to first figure out, okay, is this due to H. pylori? If it's due to H. pylori, then we use our quadruple therapy. We treat with a PPI for 14 days, and then we use our combination of antibiotics. After that, if there are, like if you look down here, if it was a giant ulcer, if the patient has a persistent ulcer, right? If you treat the H. pylori, you eradicate it, and there is still a persistent ulcer present. If they have history of frequent or recurrent ulcers, then we're going to have to use maintenance proton pump inhibitor therapy. Right? If none of those risk factors exist, then we're done after those 14 days. Over here, this is saying, look, the patient does not have H. pylori. Then we need to figure out, okay, well, why do they have this ulcer? Is it due to NSAIDs or not? And then down here, you see the length of time that we need to do the anti-secretory therapy. Here we have a PPIs like omeprazole, 20 or 40 milligrams daily. And then this is just telling us whether this was a duodenal ulcer, we treat for 4 weeks. If it was gastric, we treat for 8 weeks. And then we see, okay, did this treat it or not? Over here, yes, this was due to NSAID therapy. So still, we're just going to treat them with omeprazole. It's just a matter of how long do we give the omeprazole. And essentially, the idea is if there are risk factors, like this is a persistent ulcer that doesn't go away after you treat them with the initial course of PPIs, or if they have frequently recurring ulcers, if it's a giant ulcer and they have multiple comorbidities or they're over 50, right? All these risk factors are reasons to give a maintenance PPI. Right? Otherwise, we don't continue after that initial 4 to 8 weeks. Okay, so before we talk about the specific agents that we use for GERD, gastroesophageal reflux disease, or like acid reflux, let's just take a second to look at the things that stimulate the release of acid into the stomach. So what this is showing us is this is a parietal cell. These parietal cells are the cells that are responsible for releasing acid into our stomach. Over here, this is showing us the lumen of the stomach. So here we see multiple different hormones or chemical mediators that bind to receptors on the parietal cell. Most of these are going to stimulate acid secretion. So when acetylcholine binds, that stimulates acid secretion. This makes sense, right? Acetylcholine is part of our like rest and digest, right? The parasympathetic nervous system. So digestion utilizes acid. So when acetylcholine binds, this increases the release of acid into the stomach. Histamine, when histamine binds to H2 receptors, this, see the little plus sign, this also increases the release of stomach acid. Over here, gastrin. Gastrin is a hormone that's released when we have food coming down into the GI tract. Gastrin also increases the release of acid into the stomach. Prostaglandin E2 is the one thing that does not. So prostaglandin E2, you see the negative, right? It stops, turns off this production of acid into the stomach. You can see where different drugs are working at these receptors. So misoprostol stimulates the prostaglandin, so that would be protective. Ranitidine actually blocks this histamine receptor, so also that would block the release of acid. Dicyclomine blocks this acetylcholine receptor, also protective. Down here we see omeprazole. Omeprazole is what's called a PPI, a proton pump inhibitor. What that does is it's not working at any of those receptors. It's actually working at the actual pump that's releasing acid into the stomach. Here on the luminal side of this parietal cell, we have this little pump that pumps hydrogen ions into the stomach. And remember, hydrogen ions are a measure of acidity, right? The more acidic something is, the more hydrogen ions it has. So this pump exchanges, it takes one potassium ion in as it pumps one hydrogen ion out into the stomach. Now, if you think about it, the reason we call this a proton pump is because hydrogen ions only have a proton, right? Hydrogen itself is really, really small. The atom is tiny. It has one proton and one electron. That's it. Well, the positive charge means it's lost that electron. So all that's left is one proton. So hydrogen ions are literally just one proton. Hence, we call this the proton pump. It's pumping protons in. It's pumping those hydrogen ions into the stomach. Again, omeprazole or other PPIs block this proton pump, so we can't pump hydrogen ions into the stomach, meaning we decrease acidity inside the stomach. Okay, so we're going to talk about different types of drugs that can be used for GERD or peptic ulcers. We'll start with the H2 antagonists or H2 blockers. The most commonly used of these include famotidine and ranitidine. Other examples, like cimetidine, for example, are listed at the bottom. But famotidine and ranitidine are most commonly used. These blocks selectively block the histamine 2 receptor. So by doing so, they block histamine-mediated secretion of hydrogen ions. Note these drugs are selective for the histamine 2 receptor. They do not bind to the H1 receptor, which is important. General antihistamines do bind to like diphenhydramine, for example, does also bind to the H1 receptor, and that's why it causes sedation. These agents don't bind to the H1 receptor, so they generally do not cause sedation. Again, that is kind of dose dependent, but at usual doses, they're not going to cause a lot of sedation. These reduce the basal, food-induced, and nocturnal acid secretion by about 70%. However, tolerance usually does develop over time. So they usually work better in the beginning of therapy, and then as time goes by, they don't work as well. Now, use of H2 blockers has really decreased because of the availability of PPIs, proton pump inhibitors. Proton pump inhibitors are more effective, and they are preferred for peptic ulcers, for acute stress ulcers, and for GERD, gastroesophageal reflux disease. In general, when we talk about using H2 antagonists and kind of their place in therapy, H2 blockers usually take about 45 minutes to work well. So if you have a patient who you're not preventing heartburn, they already have it, right? They're already experiencing heartburn. If they try and take an H2 blocker, like they're going to have to wait 45 minutes for it to work. Antacids, which we'll talk about later, like Tums, they work really quickly. So if they already have heartburn, they can just take an antacid and they'll usually feel better quicker. So these are usually used to try and prevent acid reflux or try and prevent heartburn as opposed to trying to treat it once it's already there. But then we have PPIs. PPIs work better than these, and PPIs have a longer duration of action. So when you're talking about preventing heartburn, PPIs are better. When you're talking about treating heartburn, antacids are better. So they're kind of losing their place in therapy. They are well tolerated, however, in general. Famotidine, ranitidine do tend to be well tolerated without a lot of adverse drug effects. The one caveat here is cimetidine. Do not recommend cimetidine. Cimetidine has anti-androgen effects, so can be associated with some adverse drug effects because of the androgen blocking effects. It can also be associated with altered mental states in the elderly, and it has drug interactions. It's a relatively strong CYP inhibitor, so it does have drug interactions that are associated with it. Okay, so proton pump inhibitors are very, very effective at reducing acid secretion. Proton pump inhibitors include esomeprazole, lansoprazole, omeprazole, pantoprazole, right? They're all ending in azole. These agents used to be prescription only, but the majority of them are actually available over the counter now. Omeprazole or omeprazole Protonix, I couldn't think of the brand name, was I think the first of these to go over the counter, but now esomeprazole, which was Nexium, Prevacid, they're all over the counter now. Proton pump inhibitors covalently bind to the proton pump, right? The potassium hydrogen ion ATPase pump, and they completely inhibit it. So because they're actually covalently binding to the hydrogen potassium ATPase, the enzyme itself, they inhibit the enzyme for the life of the enzyme. It takes about 18 hours for a new enzyme to be made. So the proton pump will not start working again until new enzymes have been produced. This prevents the secretion of hydrogen ions into the gastric lumen, right? So decreases the acidity of the stomach. It ends up inhibiting about 90% of gastric acid secretion. H2 blockers inhibit about 70%, right? So these are more effective at decreasing acid secretion into the stomach. Use of proton pump inhibitors, these are superior to the histamine 2 receptor blockers at suppressing acid and at healing ulcers. We use them for GERD, for erosive esophagitis, for active ulcers. We use them for hypersecretory conditions, for example, like Zollinger-Ellison syndrome. We also use them for the prevention or treatment of NSAID-induced ulcers as well as stress ulcers. Finally, we just saw a few slides ago that we use them to treat H. pylori infection along with antibiotics and bismuth subsalicylate. As far as ulcers, like NSAID-induced ulcers, misoprostol, which is a prostaglandin E analog, is another agent that can be used to prevent NSAID-induced ulcers. But misoprostol is associated with other adverse drug effects that can tend to limit its use. So PPIs, proton pump inhibitors, are preferred for this. So proton pump inhibitors have a relatively short half-life. Their half-life is only a few hours, but because of the way they work, their duration of action is much longer. Remember, they inhibit the enzyme permanently, like for the life of the enzyme. So you have to make new enzyme before that proton pump can work. And we said it takes about 18 hours or so for that to happen. So the duration of action is long. The proton pump inhibitors should be taken about 30 to 60 minutes before breakfast or your largest meal of the day. The reason for this is they inhibit active pumps better. So you want the drug to be absorbed and there when you eat a meal and the pumps turn on. And then the drug can bind to each of those active pumps and inhibit them. Omeprazole and esomeprazole inhibit CYP2C19. This is really important. There's a really common drug interaction here that's problematic. Do not give with clopidogrel. Clopidogrel is generic Plavix. We use this to prevent clot formation. And clopidogrel is a prodrug, meaning it's inactive. It's activated by CYP2C19. So if you give clopidogrel with omeprazole or esomeprazole, the clopidogrel will never be activated and it won't work and the patient's going to start forming clots. And there's no easy way for us to monitor that until they actually throw a clot. So do not combine omeprazole or esomeprazole with clopidogrel. Adverse drug effects in general, PPIs are relatively well tolerated. There is an increased risk of fracture with use of over a year, but most of the indications we saw patients were supposed to be using them for 4 to 8 weeks, depending on risk factors, and then the ulcer heals, and then they don't have to continue taking it anymore as far as peptic ulcer disease goes. Use less than a year, we don't see that increased fracture risk. It is possible for proton pump inhibitors to be associated with low vitamin B12. The reason for this is acid is required for the absorption of the intrinsic factor complex. Remember that the way that we absorb vitamin B12 from the GI tract is along with intrinsic factor. Acid is needed for that complex to be absorbed. So if you decrease acid to a certain point, then you're going to decrease the absorption of vitamin B12. If that's the case, vitamin B12 supplementation might be needed, not orally. Oral isn't going to work. If you can't absorb it, it would need to be injected. Cyanocobalamin is the form of B12 that's injectable. This is the same with H2 blockers. H2 blockers are associated with the same issue. We can see impaired absorption of calcium carbonate. However, we can give calcium citrate instead. So if you're giving calcium supplementation, calcium citrate should be used in patients who are on any form of acid suppression. Diarrhea with Clostridium difficile is possible. If patients develop severe diarrhea, especially if the diarrhea has a really bad smell, patients need to stop taking the PPI and contact their physician. Right? So make sure they know that if they're experiencing diarrhea for a few days, they need to go ahead and give you a call, stop the drug and give you a call. So you can evaluate if it's C. diff, and if it is, you can treat it, which you guys know is with oral vancomycin. Hypomagnesemia is also possible, as well as an increased incidence of pneumonia with long-term use. Okay, so as far as treating GERD goes, we talked about H2 antagonists. We talked about PPIs, which are more effective. However, both of those can take a little bit of time to work. They don't work immediately. Antacids, on the other hand, do work immediately. So antacids are usually weak bases that react with hydrochloric acid to form water and a salt, or carbon dioxide in a salt. So, for example, calcium carbonate is CaCO3. That separates, and you have calcium chloride, right? Positively charged calcium, negatively charged chloride. And then the CO3 is negatively charged. It absorbs that hydrogen, right? Technically, calcium has a +2 charge, so it will absorb 2 chloride. CO3 will take up actually 2 hydrogen, so it'll be H2CO3, which is bicarbonate. Which is carbonic acid. HCO3 is bicarbonate. So we form carbonic acid and calcium chloride, right? But in doing so, we took 2 hydrogen ions away from the stomach. So we decreased the amount of acidity in the stomach. So essentially, antacids absorb hydrogen ions to decrease the acidity of the stomach. Antacids are used for symptomatic relief of peptic ulcer disease, heartburn, or GERD. They're not used to actually heal ulcers. They're just there for symptomatic relief. They do provide very rapid relief. They can also be used for calcium supplementation, right? Hence, calcium carbonate, you're giving calcium. Sodium bicarbonate is not recommended. There are all different forms of antacids. I wrote calcium carbonate. There's aluminum hydroxide, magnesium hydroxide, but sodium bicarbonate is generally not recommended because of the increased sodium load. And then also, transient metabolic alkalosis can occur as well. So we don't recommend sodium bicarbonate. Adverse drug effects of antacids really depend on the specific antacid. It depends on whether it's calcium-based, aluminum-based, magnesium-based. For example, any aluminum-based agent is more likely to cause constipation, whereas magnesium-based agents are associated with diarrhea. One thing that's important to keep in mind, these should be avoided in patients with renal failure because accumulation of cations can occur.